Good morning, everyone. My name is Chastity Childs with Community Infusion Solutions. And thank you for joining us today as we discuss the outpatient infusion therapy, the highest ROI to hit rural America since the plow. Today, I have the honor of introducing Mitchell Brinson, our founder and NRHA fellow, to discuss this topic along with his colleague, Tim Thompson, who has been in rural healthcare for over 40 years. And just want to let you know that any Q&A that you have, feel free to drop it in the chat. And then also my contact information will be on the last slide as well. Thank you and enjoy the show.
Well, welcome everybody. Thank you for taking the time this morning to talk about outpatient IV infusion services. I'm a public health person. Grew up in healthcare in the late 90s in graduate school, and really that was really about the time when people were beginning to look at data and trying to think of better ways to take care of patients and help them along the care continuum. And really outpatient infusion is one of those services. So I wanted to talk to you a little bit more about that. A little bit about this is our agenda for the day. So we'll talk a little bit about our firm, but also just the rural health paradigm, kind of what's going on in rural health and things that you're probably familiar with. A solution around outpatient infusion, around some of the goals that are really top of the list in rural today. The service model, the financials, and a customer perspective. Tim Thomas is a former CEO and CFO for many rural hospitals. He can kind of give his perspective, and then we would love to take some question and answer from your perspectives. So our company, Community Infusion Solutions, was founded in 2008. I'm one of the founders, and really the development of the company was really an outcome of seeing patients in rural areas from where I lived, both in Maryland and in Texas and in Oklahoma. I worked for large healthcare organizations like Johns Hopkins and Baylor Healthcare System and others. And what we saw was that we would observe patients coming into the urban setting for that acute care, life flighted and so forth. But then they would be released to go back home and get all their post-acute care. And what we saw was that a lot of patients in the rural areas just simply didn't have the amount of the needed drug in their blood system. We could see that through labs. And so we came up with a program that would put the IV infusion programs into the rural communities so patients had really ready access to that. And then we really worked hard on trying to improve the process of how they receive those infusion services so that we could achieve a very high patient adherence score, which is that 90% here. So our company has developed 130 programs in 22 states over these years, and every single one of those programs is up and running. So it's a very sustainable service line. And we generate a lot of money for rural, $65 million in cash every year, and that's growing dramatically. And we're the largest organization of our kind in the United States. So kind of what's the problem? As an NRHA fellow and as a scholar, I try to stay up on the latest and greatest commentaries, and really it seems like the large point is that all rural hospitals need a strong ROI service line, whether a critical access or a PPS hospital, with a low cost of entry. In other words, it doesn't cost a lot of money to get into it, and that they would be able to access those existing patients. And certainly rural has many great opportunities. If you're in real estate, they would say location, location, location. Well, rural has location, location, location. But what they don't have is they don't have a hematologist or a gastroenterologist. But there are so many different kinds of services that can be offered for patients that need those kinds of services right there in your community, so that the hospital is generating those revenues, even though they may not have the specialist. And so that's really the opportunity, because outpatient infusion outpatient infusion indeed offers a very strong opportunity to generate charges and revenue, but doesn't require a lot of upfront costs. So it works very well, and I'll try to give some good examples of that today. So for the program and for our company, we're a turnkey solution for the development of outpatient infusion programs. We know that every hospital in the world has outpatient infusion. I got to spend some time in Africa, and they were doing outpatient infusion in these very remote areas. But again, creating an outpatient infusion program as a service line, something that's budgeted, that has a cost center, it has a marketing expectation. That's really the kind of program that we wanted to be able to develop to help these rural communities really serve as many patients as they can and hit their mission. So for us, our average ROI is greater than 200. So when you look at the cost of putting in some chairs and some infusion pumps and these sorts of things, and then look at the revenue opportunity that comes from that, the ROI is extreme. It's very, very high. The net operating margin is around 30%. So for every dollar, ultimately on a monthly basis, for every dollar one invests, you're getting about $1.30 back. So it's, again, very good, very strong. The startup cost is about $40,000. And the initial investment break-even point is typically within 60 days. Again, we have the ability to do a very deep dive analysis. So this isn't a situation where we'd say, well, let's just go ahead and develop a program and then let's see what kind of revenue it generates. And I think this is a topic that Tim can help support just based off of his experience. The other nice piece is that the startup period for this program is very short. 99% of hospitals don't build out space. They typically already have pumps. They usually have somebody, a nurse, that has interest in doing infusion services and learning more about that. So again, the startup period is very short. The number of days to break even is very short. So it's a very attractive service line. So to kind of talk a little bit about this, and one comment to make that I think would have made good sense I could have made earlier is that the reason why you guys are on the webinar, and I'm so appreciative that you had interest, is that your facilities had an out-migration of at least $500,000 for infusion services, and your market share, your current market share, is less than 25%. So we know this through our Medicare data that our organization buys, and so I'm hopeful that you'll find that this is very relevant again for your facilities. So what is outpatient IV infusion therapy? So patients are diagnosed in an urban or rural setting from their physician, and they require IV therapies, IV antibiotics, or biologic infusion therapies for rheumatoid arthritis and things like that. But again, these are patients, they need to have this therapy. These referrals often come from the primary care doctor, oftentimes from a hospitalist in the facility. So at that point, once the order is written, well, then they're going to be referred to an infusion provider. That could be done at your hospital, that could be done at the hospital down the road, or at an LTAC, or even home infusion. So there are many different options for patients and what kind of infusion therapy that they might receive. These are serious diseases. Certainly cancer is a very serious disease, but osteomyelitis left untended will kill you very quickly. So again, these are patients that have to have this level of systemic therapy, and really that's key. Many patients that receive infusion services, like myself, I've got psoriatic arthritis, so I receive a monthly infusion. I'll be doing that for the rest of my life. So once you build a base of patients relating to these different infusion types, then for a large portion of those patients, they'll be with you for a long time. And really for nurses that are on the infusion space that are involved in that, it's a great place to be because they get to know the patients, and the patients get to know the hospital and really interact, and they ultimately become quite a spokesperson if this is all done well. So patients receive, as I mentioned, daily, weekly, and monthly infusions. So an example, And again, there's always options. So we have a patient that's in the hospital. We need to get them out of the hospital. So the choices are you can either send them out to a home infusion company, which is obviously very easy to do. The form is probably sitting there right by your discharge planner's desk. They just fill that out and send it down the road. This particular example, patient 73 years old with a bone infection. They're not a candidate for swing bed. Infusion services and swing bed sometimes overlap a little bit, but by and large, infusion services in the department that I'm talking about are very standalone from a swing bed program, so they're not going to be taking any business away from that. This patient had Medicare and a secondary, and then they were on 2 drug therapies. As it currently stands, Medicare does not pay for home infusion for antimicrobial, for IV antibiotics. And so ultimately, the patient's going to have a rather significant out-of-pocket, $6,200. If this is done inside the hospital, then the cost is nothing for the patient. The other piece of this is that if the patient is sent to a home infusion environment, they're going to be infusing themselves. And so there's data that's out there that talks about that the adherence rate for patients receiving therapy in the home is very low. It's less than 40%. So if they're done in the outpatient infusion space, at least within our model, then they are going to show up 90% of the time. Otherwise, it's a little bit less. So the patient's going to be paying more for services, plus their adherence rate is going to be dramatically less, so chances are they're not going to get well quite as quickly. I think the end point of this is that if the hospital can keep that infusion service within their own network, then not only are they going to be controlling the quality and the outcomes for that patient, but they're also going to be generating quite a bit of revenue. And for this particular example, it's about $10,000 that the hospital would generate in profit from that infusion cycle. So the model that we work in, again, turnkey, is that we will have completed an analysis for your organization. You will have shared some data with us, and we'll present that to you at no cost. And then at that point, we begin to do the market development, and that includes social media, that includes boots on the ground, human beings within a CRM, a sales management tool, and they begin to market this program. The marketing of the program is done, again, by our team, but we very much are marketing your program. So the organizations on the outside, they don't know who we are. We work for you guys. So that market development also, again, is within physicians, but also goes after discharge planners and others. And since we have a lot of Medicare data, we can see where your patients are going. And so naturally, we begin to target those providers. We'll also put out a postcard that says, look, you can have these services done locally. All you have to do is call your case manager, and your case manager is then going to take care of all of the elements to get that patient's order written and then sent over to your hospital for that activity. So that activity in and of itself, nobody at your hospital is engaged in that. That's all done on our side. So case management is the cornerstone of what we do. Our case managers are nurses and pharmacy techs and social workers, and they have a psychological profile that they have the ability to create familial relationships with patients. They're really good at gaining trust of patients and providers. That case management person is going to receive that order, and that's our case manager. They work in Texas, in Dallas, where we're based, but they are the single point of contact. Referrals will come in through the case manager. Those referral sheets will be ones that we will have created, and we went and marketed for those services. And then from there, the case manager then reaches out to the patient, lets them know that they have this order. And then our team begins to do the insurance verification and authorization side. So a lot of organizations oftentimes will have the physician's office do that. And of course, physician offices are busy. Their nurses are really busy, just like your nurses are really busy. And so that's something that our team takes on. That's all done in a proprietary information system that we've developed. So if there's ever questions around the insurance verification or that component, then we have the documentation to support that. Anything relating to medical necessity, that's our job. We ask the right questions of the providers, get the medical records, make sure that they fit correctly. And if there is any interaction with the payer around that medical necessity, that's our job. We want to take that on. Again, letting your team, your clinical teams, do what they do best. At the end of the month, we do a financial review. I should say for every patient that comes on service, we do this financial review to, again, make sure that the drug cost is what we expected, that the reimbursement is what we expected. And so there's never a situation where you're providing these infusion services and then all of a sudden you find out, hey, it's only paying this many dollars and the drug costs this many dollars. So it's a very safe and secure model of a check and balance system that we have, again, very seamless with your operations. One thing to note about this entire program is that all the information is within your patient accounting system. This isn't siloed in another system, for instance. We do have some elements that are standalone, but again, all the elements relating to billing, collections, quality, patient engagement, and so forth, that's all done within your system. We also provide revenue cycle support. So 40 hours a month we would make available. So if there's ever an issue around the services provided doesn't get reimbursed for some reason, then you reach out to us, and then we get our collectors involved to help support that activity. And then, of course, at the end of the month, there's some monthly reporting. At the end of the day, the hospital is going to provide the drug, the nursing, and the space, and then our organization does the rest. We talk about something called a Regional Infusion Center of Excellence, and this was a term that I learned quite a bit about when I was at Johns Hopkins. But really what it means is that you're setting some clinical and volume standards in order to gauge and try to improve upon. Those measurements are at least 40% of the volume for your program is going to be referred by providers outside of your community. Your patients certainly go to specialists and other places, and we would be marketing to those people. The other element is that the adherence rate for patients showing up for therapy is 90% within our company. So rather than a patient showing up for 40% of the time or 30% of the time, they show up dramatically more. We market that success by patient to the referring providers, so the referring providers know that their patients are succeeding and that they're very pleased with the program. And from that, it drives some really great referrals as well. So this is an example of a pro forma that we would like to build for you, kind of on the due diligence side. And for this particular program, this is a critical access hospital out in rural. They generate $934,000 in cash flow and about $302,000 in net margin, so profit margins. The cost to set up, as I mentioned before, is $40,000. And then we get paid just the same way that you do. We want to generate revenue. We want to generate volume. So we're getting paid $80 per antibiotic and $120 for nano-antibiotics, and then a flat rate per claim of $50 to help support the accounts receivable and so forth. Many critical access hospitals choose to get a flat rate for these services, and that's something that we can do once we've built out the pro forma. As part of the pro forma, this is kind of an element of this, and there's other pieces of the pro forma that are really neat that talk about your community and talk about some of the challenges around diabetic foot infections and patients who have cellulitis and UTIs and things like that. But this gives you a really a good high level view of what we focus on and how we try to achieve success. So when you look down this left-hand side, you see antibiotics, anemia, and asthma, and neurological diseases. These are product lines within outpatient infusion, and these are the elements that we want to be able to market towards. So for instance, this is a budget. The pro forma will ultimately become an operating budget that can be shared with the board, and then we would use this as our tool to make sure that we are doing a good job on the marketing side. So in order for us to achieve referrals for antibiotic patients, Certainly that relates to your own facility, but also other facilities. So, like for instance, pulmonologists dealing with pneumonias, podiatrists dealing with diabetic foot infections, or infectious disease providers. So that relates to this piece. And so when we're out there marketing this program, that's going to be an element that we'll be involved in. The expected payment is based off of a OPPS Medicare fee schedule. Certainly for PPS hospitals, that makes sense. For critical access hospitals, you have a percentage that you receive from the federal government. When we begin to have our discussions, then that would just be something that you'll share with us, and then we have the ability to give you an idea of what the charge amounts that you'll be generating, and then the revenue that would come from that. The drugs are 340B or not 340B. Half of our facilities don't have 340B, so that's not fundamental, but we have a pretty good idea of what it is. The nursing component is just simply mathematics. Nurses can manage a certain number of infusion chairs at the same time, and certain infusions take a certain number of minutes, and so that's just built into it. Total operating expenses includes everything that we've talked about on our side, as well as the drug and the nursing and so forth. And then the profit margin and the ROI is as you can see it.
Mitchell, we have one question.
Okay, please.
Can you review the ongoing associated cost again? Is flat rate versus an infusion rate plus the $50 fee?
Sure. Okay. So what we charge for the program is we charge $40,000 to develop the program. That includes our marketing visits. That includes really all the setup, a lot of hard costs on our side. And then once the program has the kickoff, which again, it takes us about six to 8 weeks to get it kicked off, then we charge per infusion. And it depends on the infusion. So if it's an antibiotic infusion, then it's $80 per infusion. And for non-antibiotic infusions, then it's $120 per infusion. And then the last element is a revenue cycle support side to get that 40 hours a month that we can help on any issues relating to coding or billing collection, things like that, is $50 per claim. So in this particular model, we don't charge a monthly flat rate. A lot of critical access hospitals have requested, and we have contracts where we do charge a flat rate for simplicity. So that's how we get paid for the services that we provide. I hope that answered your question. All right. So Tim. We've got Tim Thomas on the line with us. I wanted to ask you just a couple of questions and have you talked a little bit about it. So, what was the situation at the hospital you had led before you implemented an outpatient infusion program, a cost center based program?
I tried to do it internally, working with the business office and the emergency room primarily, and we didn't do a very good job on case management or insurance verification. We really didn't do a very good, because we just didn't have the experience in it. And the results were very poor. And so that's kind of what the status of our infusion was before the infusion. You know, I met you and talked from Community Infusion Solutions at a conference. And you were talking about how you could do outpatient infusion as a profit center, and needless to say, I was, no pun intended, a doubting Thomas, because I had just been through the experience and couldn't make it work, and I didn't want to admit that I was, totally inept at doing that. So of course, there was a very minimal investment in terms of, and you all were taking the risk since it was a pay-as-you-go kind of a program. So I said, sure, you think you could do it? And frankly, I wasn't sure, and I had my doubts that you could. And y'all came in and totally put in an infusion program that was, incredible and a whole lot different than, there's a lot more to it, obviously, than we thought. And within 3 months, I mean, we were at 75, 100,000 collections a month in infusion. It's just an incredible startup, and the program. I was with that hospital for another 3 years after that, and we run about a 50% operating margin. So for every dollar we spent, we got $1.50 back. So it was just a very successful program at that organization.
Wonderful, thank you. Knowing that, I guess that Tim's having a little bit of a challenge, I'll go ahead and just try to work on that last question. Did the infusion program influence the hospital's growth in other areas? And I'm extremely proud to say that it in fact did, and that we developed a chemotherapy program for the hospital. Because when you think about the ability to provide medical oncology in rural, the most important thing, honestly, is adherence. If the big city oncology groups can believe that the hospital in rural that those patients will be adherent, that they're going to show up for therapy, and that there's a very clear, obvious program there, then they will refer those very intensive services. Most of our programs don't do oncology, and that's something new for our company that we've really gotten involved in. But we currently do a lot of infusions that relate to multiple sclerosis and lots and lots and lots of other areas. Many of them are really large into ancillary services like lab, radiology, and things like that. Thank you, Tim. What we would like to do is to schedule a time to talk with you and walk you through a level 1 analysis. The level 1 is really going to look at your Medicare out-migration, where patients are currently going, and really just to have a conversation. It only takes about 30 minutes, but I think it'll give you a lot of great information that will help you choose to move forward with us, or to go it alone, or to not do that at all. So the second element is this deep dive level 2 analysis, and that was the example that I gave just a moment ago, where we're actually looking at the service lines, and we're looking at the revenue, and we're really building it in the development of that business case. And then the last piece is just to implement the service model. So that's really the kind of the steps for us. And these are done, those analysis pieces, the level 1 and the level 2, those are done at no cost to the organization, to your organization. At this point, we'd love to take some questions. I'll let Chastity, why don't you take it from here? And thank you for your time.
Thank you, Mitchell. So now we'll open it up for our Q&A. And I already have a few questions here. The first question is, how does the program fit into where Medicare is going?
Sure. No, that's a great question. My goodness, isn't Medicare a challenge to try to figure out what their path is? So I was at an NRHA event and an American Hospital Association event, and really the focus was, as we all know, the movement of inpatient to outpatient services. But I think the other element that was included in that was also that the intensity of those outpatient services would be growing. In other words, that not just providing, say, basic hydrations for infusion therapy, but being able to provide more intensive services. And those, at the end of the day, represent more revenue, which is a good thing, but it's also something that the community needs as well. So expanding services in the outpatient area and being able to take care of a larger, broader array of patients in those local communities, as the urban hospitals are struggling to take care of anybody at this point. They're overwhelmed. Thank you for that question.
We have another question in the chat. What is the contract commitment period for services?
Sure. We'd like to get contracts at least 4 years. I think our boilerplate puts it at 5, but we seek to put it at 4. And really, as you can see, our model is most of the hospitals that we work with have no infusion programs whatsoever. They're very, very small ones. They're generating, say, less than $150,000 to $200,000 in revenue a year. And so we're going to set that up. For our company, we're going to put a lot of energy on the front end to build those programs up and to get them to doing well. And we want to be there long enough to enjoy and to grow the program both in quality and volume with the hospital.
Wonderful. Who does the marketing for the program, and what about communicating with referral sources?
Okay, so we know marketing. I mean, my goodness, your charge master alone says it all. You probably have 50 or 60,000 items that you have in your hospital. So having somebody to market a program like this, it's very, very specific. Our company takes that responsibility. We've trained account executives to be able to do that, and again, they will then follow up with the referring providers and new providers that we would like to see referring patients to the program. They're going to give them lots of information and really be a huge support arm for that provider office, specifically the nurse. So that they have the ability to do other things, and they lean on us because again we take some of the burden off of their nursing teams. So again, that's what our marketing folks do.
Well, here's another one for us. If a facility already has an established program with a team for referrals and revenue cycle, but is interested in marketing, do you have options for customizable services?
Sure. So what we can do is we want to be able to case manage those patients. Case managing the patients through the referral process is key to that marketing element. If you can create a 90% adherence rate for patients, then they're going to go back to their doctor, and their doctor is going to say this is a great program. The revenue cycle component, that's something that we can discuss. It wasn't our intention to get heavy into revenue cycle. We really wanted to focus on broadening access to those local services for infusion components. But we also want to make sure these are in some cases expensive drugs, and to not have some sort of check and balance system around that reimbursement component. As Tim Thomas was suggesting, that can get a little bit out of hand. And so we want to make sure that, again, somebody's got a finger on that, and that you don't end up, for instance, a patient is referred for an infusion service. The hospital checks their insurance. Everything looks great. They have Medicare, traditional Medicare. It's easy enough. So then we begin to infuse the patient. And then 2 months in, they move from a Medicare to a managed Medicare product, we'll say. Well, that has a different authorization process, as you know. So if somebody is not every month looking at that verification of authorization of services under their insurance, then nobody would have ever known that they made that change. 6 months down the road, somebody catches it because the AR for that patient is growing, and they would have initially seen that they had Medicare, and then once they evaluate it, then they realize that they've got a bit of a problem. They provided services without an authorization, and now the collections team's got a little bit harder job ahead of them. So again, the marketing component is very, very important, but what I might suggest is we could customize certain elements of that, but a little bit of that AR review is still very important for the sustainability of the program.
Hey, I have a few more questions for you. Would this program be eligible under the 340B?
Sure. So 340B is certainly a program created by the federal government to provide low-cost drugs to hospitals that take care of disparate populations. Absolutely, this program is very, very much tied into 340B. 340B provides oral medications, which of course that doesn't relate to us, but for those outpatient services like infusion, very much so. So to give you an example, multiple sclerosis patients oftentimes receive a drug therapy called Tysabri. Tysabri is a very expensive drug, and they're going to receive that once a month for life. That drug cost without 340B is $3,000 to $4,000. With 340B, it's around $900. So it's a dramatic difference in cost. So, and again, there's a lot of profit that's generated from that. The neat thing about 340B is that the profits from 340B, again, go back to the community in the form of different programs and service offerings that the hospital can provide. So this program will generate a lot of 340B profits and revenues that then can help your hospital drive that mission. And from a revenue standpoint, this would be the flagship program for your 340B model.
So we have another question in the chat. So someone missed a few of the slides. For profitability of the program, should it be inside the hospital, or would a building on the hospital campus outside the walls of the main hospital building generate the revenue illustrated?
Sure. So I guess the question is, it depends. Most of the infusion programs that we develop, they are within the hospital. For instance, just in a small room that they're probably not using, or even a patient bedroom that's not being used. Most of our programs are inside of that model. The blessing of that is that you get to benefit from your registration. It's already at the hospital. There's a nursing station. Your pharmacy is close, and these sorts of things. There are other programs that are on the outside of a hospital, for instance, maybe across the parking lot, for instance, and those work just as well, as long as it's on your Medicare cost report. If it's not on your Medicare cost report, then you won't be able to benefit from 340B. So as long as, and again, the last element to that is that for patients, the simplicity, that's a really big key component. People always ask us, how in the world did you get to 90% patient adherence? And a lot of that has to do with things that our case managers are doing. But I'll tell you, a secret is a large piece of that is that the patient knows when they open their eyes in the morning exactly what's going to happen to them at their infusion that day. It's not going to be willy-nilly. They know they're going to show up at 10 minutes to 9. At 9 o'clock, they're going to go back. They will have already registered. They'll get to their infusion room. Their infusion room is going to have a chair right next to their chair. It's going to have all their pre-meds on it. So again, there's a lot of predictability there for the patient. And from that, if you look in the literature, that's a big indicator for whether they'll be adherent. So those are the thoughts. Yes, thank you.
So last but not least, there's already a nursing shortage. How does this service model impact us in that area?
Sure. So our case managers will be the ones that will be doing the scheduling of the infusions for patients. And this is something that your pharmacist can look at, and the registration people can look at, and the nurses can look at. It's an online scheduling tool that we have. And with that, the nurses and nurse leadership have the ability to schedule their nurses within very specific times. So, for instance, if you have 3 patients infusing in a day, you could have them infuse at 7 in the morning, noon, and 4 o'clock. Or you can maximize that by clumping those patients together. In some regard, maybe a doctor would write an order for a patient to receive a twice-a-day infusion therapy. But maybe that's a challenge from the nursing standpoint. So our case managers would go back to the doctor and say, is there another drug that's in the same class and trade that's only once a day, because we're struggling with the ability to cover that infusion. We will get the order updated, send that through, and then our case managers will make sure that the scheduling side of that is improved. The other side of that is that if there's ever an issue that even the nurse may have, they'll push that right back through our case managers, so they're not waiting on the phone with the doctor, the doctor's office. And so really the nurse is going to be infusing patients, taking vitals, and doing some charting. And other than that, that's it. No other kind of administrative services. So generally speaking, our nurses, the infusion nurses in the facilities, we're very subordinate to them. We understand that we got to keep them happy, but also keep them productive and optimistic and positive. And overwhelmingly, that's the comments that we've been able to receive back from them. So thank you. That's a great question. Yeah, nurse shortage, that's a challenge.
So I want to thank you all for attending our webinar that we put on today. I will let you know that we have a video that we just released that talks about the nursing shortage and how Community Infusion Solutions helps with that. Also, in the coming days, you will receive a recording of this presentation, as well as I will be reaching out to you directly to schedule level 1 analysis, and feel free to reach out to me directly if you have any questions or concerns that you weren't able to address.
Wonderful. Thank you, Chastity. And I guess as a last comment, if nothing else, you're considering your outpatient infusion program. Think of your outpatient infusion program as a very primary element for your chronic patients, your diabetics and others. And at a minimum, consider that level 2 analysis. Again, it doesn't cost anything to have it done, but it will give you very much a very detailed understanding of what your program could create for your community, and be able to answer that question. So again, thank you so much for your time today, and have a wonderful week.
Thank you. Y'all have a good one.